Thank you all for coming. I know that I'm busy, and I expect many of you are more busy. And it's not a competition, but I value your time and mine. So carving an hour to listen to a talk that might not be actionable for you, I really appreciate it. And maybe it is actionable. So I'm going to share my, particularly with a focus on the project I did with the master's program here, share the results from this CSRS 2.0 visioning project, and then a tack on at the end. It's a related project, though, different funding stream, but on the same data, same opioid data, how we're now visualizing that in a dashboard. So let's see if we've got this going here. Can you hear me on that, my recording? Okay, great. So again, I'm going to do a little background first for those that don't work directly and full-time in opioids, then quickly into this Visioning CSRS 2.0 project with UNC IFRIC and the Department of Mental Health and Substance Abuse. That's broken up into research, some stakeholder meetings, then a couple of informatics outputs. I'll get into those details once we're rolling. Then the second project, this Opioid Action Plan data dashboard, which is going live at the end of the month, and we rolled out at the OPDAC meeting for a good 150, 200 folks on Friday. So background first. These three slides are sort of the typical way that we're now framing the opioid epidemic. We're sharing this as part of the Opioid Action Plan. So pain as the fifth vital sign in 89, a couple of strange articles suggesting that there's no possibility of opioid addiction, and now we see drug poisoning for all intents. That includes opioids, and opioids are making the bulk of that for most of this run. More than motor vehicle deaths. So this has become a really serious injury outcome and actionable. So here in North Carolina, we were looking at opioid dispensing per 100 persons, so measures of opioid oversupply and opioid rates per 100,000 persons, and broadly they line up. So the idea, not too radical, that if you saturate a market full of opioids, you've got folks building addiction, diverting, causing death. We're now around the order of about 1,300, 1,400 deaths a year here in North Carolina, more than opioid, drug overdose related. So that this epidemic has changed a lot in the past, particularly since the 2000s. We're starting out in a very opioid-centric overdose, where we're looking at prescription opioids in particular. And now we're looking at more heroin, fentanyl, other synthetic narcotics as making up, by our last quarter measurement with the opioid deaths, 60% of opioids. So it's no longer really just a prescription opioid epidemic, which it really started as, where that was 90% of opioid deaths. Now that's much less. So that means that PMPs, which we're going to get into, prescription drug monitoring programs, that means that prescription drug monitoring programs in particular, they're not tracking these synthetics. So PMPs become an important part of the solution, but not still the fault. Connected to this is our state's opioid action plan. So tagged on the left are the CSRS, which is our state's PMP, the metrics that we're getting from that system. So, and again, with the idea that PMPs aren't the only way we're tracking this, they're not the only solution. They're not the only thing we're tracking either. But CSRS makes up a big, important chunk of how we measure oversupply in particular, and then now we're getting to measure treatment and recovery as well. So PMP context. So North Carolina's PMP is the Controlled Substance Reporting System, CSRS. Started in 2009, but really ramped up with an updated use in 2010. CSRS collects prescription, prescriber, dispenser, and patient details within 72 hours of a dispensation. So it's if you're doing EPIs, that's more of an intent to treat. So you have to pick up your pills. This isn't necessarily people are using them; they may not be taking them themselves. And it's not just being prescribed; it has to be rolled out and picked up. So historically, then we're using that data to address prescriber diversion. That's being done through boards like the medical board, and then basic prescribing patterns. It's beginning to be used for research, but it's largely unlinked as a data set. I know of at least a couple around me, different linkage attempts, but I would say the data set is underutilized. It's fair. CSRS is managed by a third-party vendor, APRIS, which basically has a monopoly over the U.S. marketplace at this point. I think it's 47 states by our count. May change here and there, but it's basically a monopoly. Then at DMH, what happens is that every month a local flat table download is provided by the vendor. So we pull that down. It's kept as a giant flat file. So if you do big data work or informatics, this is not a very friendly way to do data analysis. It's very non-normal. There's still that time lag of a month. Not a lot of data cleaning work that's being used, but that's sort of the state, is that the vendor houses the data and then we get a snapshot of it.
Has anybody connected it in some way to their HIE?
So there have been attempts. We'll talk about some of those here, not in our state.
I know that.
Yeah, not in our state, but nationwide, there have been folks who have begun to at least do linkages within the same data sets that would end up in an HIE. So big EHRs up in Kentucky, they're doing some linkage to Medicaid claims in another place. So things are happening, but I don't know of any gold standard. We've got this moving and rolling in an HIE, in a true, like, fully embodied HIE yet. So CSRS 2.0. So why would we do this? So CSRS requires a separate login for providers. Entity resolution is tough, so knowing that the patient is the same patient and that you're not splitting that historical data up into 10 patients, very important for measuring these longitudinal metrics. There's no EHR integration, again, separate login, so that means that folks have to come out to log into a new system if they remember their username and password. It's very hard to digest. This is actually what the dump looks like that providers see. And I use the word dump somewhat intentionally. And so the NC Stop Act, which is effective January 1st, 2018, is requiring prescribers to use the system, which is very tough to use. So there's this interest from providers, researchers, healthcare systems, and can we do better than this? Prescribers surveyed said that pre-Stop Act, only 1 in 4 use it. Now, we technically supposedly have log files. I haven't worked with them or seen them, but there may be some way to, informatics-wise, do that measurement or survey. And that they said that it takes too long to do this during an encounter. This is really not sustainable for a workflow. So then the contract design with UNC IPRIC was to make a research push first. That was with a lit review, statewide partners, and national partners search. Then we had some stakeholder meetings, which we'll talk about. And then out of those combination of things come our informatics output. So our EHR integration wireframes, a data quality assurance document that we came to, sort of became a late deliverable that we saw was really important. And then a couple of other informatics considerations that we just felt there's no other place where we have to say them somewhere. So they go in. So on the research side. So first, the lit review. So again, the big point here, there's not a lot of literature about these. PDMPs rolled up, again, around the same time as ours in 2009, thereabouts. So you need enough data, enough time to use these to really get outcomes. And it's tough when there's this epidemic with many other interventions at the same time. And there's a non-standard rollout of these PDMPs, right? So every PDMP is a little bit different. It wasn't until recently when APRIS bought out many smaller companies that there began to be consolidation and a more homogeneous interface. Some places had required providers to use it more early than we did. And so there's a lot of different implementation differences here. So there's mixed evidence regarding then their effectiveness. That looks then like PDMP utilization seems to be a really important factor. So more utilization by providers makes sense, does more. And then I mentioned that popular press, 1 in 4 doctors use it and it takes more than 5 minutes per patient. So they quote providers as saying we need a more user-friendly interface, a visual list of medications, and integrating the database with the CHR. So these are kind of duh points in a way, but we're just not there yet. So they're reprioritizing these things. Barriers, again, retrieval is time consuming, data is not user friendly, it's not needed for all patients. So, CSRS technically also has pet meds and some other things that have different, you have a cancer patient in there along with a dog prescription. So those look different. So again, other recommendations include standardizing that content for providers and then using push notifications without alert fatigue. We'll talk about that. So we met with 2 stakeholder groups at UNC and Duke in the late fall and early spring, but statewide partners, as we're making the search, this is a lot of different people interested in this opioid question more broadly. Yeah.
Sorry for interruption.
Sorry.
If you go back to the previous slide, last item,
Yep.
you mentioned a database used by doctors. What is that database?
The CSRS.
Yeah, just so, yeah. So yeah, integrating CSRs with EHR so they don't, for many reasons, so they don't have to log out, log in. So they have the visuals right there in terms of time and the workflow. Yeah, that's right. So, but there's many folks besides Duke and UNC. So this was providers, informatics teams, sort of the C-suite of folks, some attended, and then researchers, with the folks we met with. But there are other healthcare systems. There are regional differences between those healthcare systems. Licensing boards, there's not one, there's many. Associations, healthcare association here, really important group. Providers, so again, we have a cancer doc and vets and pain specialists and everything between are all prescribing. And I'll say, we'll talk about this later when we talk about the wireframes, but even within a single EHR family or landscape, so Epic, what a cancer doc sees in Epic is different, very different than what a pain clinician might see. And so there's just a lot of variety in that provider group and their needs. Same with dispensers. So again, this data comes back out of systems like the CVS, UNC's prescribing dispensation system. So, they're also they're the ones inputting the data, and so data quality is really coming from that spot. And so managing them, communicating to them when there are problems is important. And then there's a whole lot of non-user stakeholders. We don't get to have accounts, but law enforcement, public health, researchers using this data, community groups like NC Harm Reduction. There are a lot of folks using this data, looking at aggregate metrics who aren't in the system. And all those folks have an interest in the outputs and data quality of the system. So we also did a national search. I think we sort of deeply researched maybe half the states, and then did interviews with maybe, I think I called 6 different states, folks who run their PDMPs. So a lot of those, particularly the interviews, were really interesting for folks who are doing a better job, or doing it, have been far along with integration of these systems. So folks had already been ahead in terms of data linkages, who are already done a lot of this entity resolution work, and so they're able to join Medicaid data, outcome data, right? So this is just prescribing data. We don't yet. There's a project now working on this. We don't yet have those joined to the outcomes. So it's very difficult to evaluate how good our metrics are without knowing, did this person overdose? Did this person die? And so there's projects just now. Again, it's 2018, and this rolled up in 2009, 2010. We're looking at the link of those, which seems very important. So give us help in metrics. Informatics vendors, there are other folks who are ahead enough to have hired the same folks we're considering, fired the same folks we're considering in some cases, hired other folks, tried different systems with the same vendors. So really doing that national search is going to be really important. When there's other outcomes coming up, other opportunities coming up, where we're inviting some of these folks down to North Carolina to give us some feedback on what they're doing. So yeah, so that's particularly Tennessee and Kentucky have done some really interesting things, different in both cases, but and then again, ACRIS is a near monopoly. So other states who have third-party vendor relationships with SAS and IBM, ones that we're still developing, can give us some guidance on what's worked and what hasn't worked. So that's the research set. So stakeholder meetings, I'm going to kind of keep short because we've tried to take a lot of lessons learned and roll them right into the deliverables, the informatics deliverables. So you'll get a sense of these stakeholder meetings also through what we ended up building. But we had, again, 2 in-person stakeholder meetings with Duke and UNC. We then had some targeted follow-up meetings. So the Duke Institute for Health Innovation folks were some really interesting partners we've had some great conversations with. And then some folks also gave us feedback once we developed these wireframes and informatics deliverables to then say, that looks great, but I meant this. And so we were able to tune what we got at the end. So those stakeholder meetings also included researchers and other institutions. So in that group, researchers and institutions, and they emphasize data linkages. So that looks like, when can we get access to this data? What do we have to sign? What data governance has to change? Where's the policy in order to get us to get linkage happening more quickly? data quality assurance, so researchers that had experience, this is partly how this deliverable spawned off from these stakeholder meetings where folks said, I would use it, but I don't trust this metric at all. This is behind the times in terms of the literature review. Like you've got to look at how we're counting MMEs, milligram morphine equivalents. You can't just add these up, and so we delete the metrics you give us and rebuild them. And so a lot of tension like that came out, and so we tried to then wrap that up in a deliverable that we'll talk about. Clinicians prioritized. I think sort of the most interesting tension to me was in the clinician feedback, where they want interpretable metrics that are also predictive and aggregate, but still interpretable. So it can't be a black box. It's got to look at a lot of things, but then it can't be a black box because they can't act on it. I can't say, well, this math says that you're dangerous. That's not how that's not how protection of provider getting sued works. You can't point your finger and say, well, this product told me blah, and so that has to be a different kind of evidence. So they wanted to also see data visualization, EHR integration, and then these HIPAA issues we'll get into as well, where they're saying, I'd love to see whether this person overdosed, which I currently can't if it happened outside of my healthcare system. But can I ask for that? The second most asked for metric was, has this person previously done any drug diversion? And whether or not ethically they can see that. Legally they can see that as a question. Informatics teams recommended different pieces, so they're like, well, this is all great theory, but roll up a pilot project and let's try something in a small clinic somewhere. So folks offered, we have grant cycles coming up, for this would be very doable. Let's build some small application in a phone. Let's start to work on these metrics to see how they actually, lead into a workflow. Because without that work, this is just great theory. Still important to do, and so where a lot of these outputs are sort of at the theory level that would then have to get instantiated in research and pilot projects. But that was great feedback. And then the conversation with just these stakeholders ended up, I think we had 40 or 50 folks in the full list, and I think in the end maybe 20 folks came to in-person meetings. But that's just 2 healthcare systems, so we're looking at really hundreds of stakeholders who have valuable expert insight into the system, because opioid touches so many different settings. So now into the 3 major informatics deliverables for this. So wireframes is the first. So what we did was we took the stakeholder feedback from these meetings and tried to really operationalize them in a visual way. It's really tough to say, I want to see a yellow, red, green light, and okay, well, I'll put that on something, and then let's give you some real feedback. So I'd also say, we're taking this feedback and making something with it, but it's really the first iteration. We did some tuning of this first iteration, but it hasn't been tested or rolled out, or no workflow conversations. How do you actually use this in the clinic? All conversations that have to happen later. Again, untested. So, folks said, yeah, but what if that metric says it's a 4.2 out of 5? What do I do as a provider? It's not enough to say it's dangerous. I have to know how to incorporate that into a decision-making tree. So again, idealized. So it's loosely based on Epic's module layout, where they've got sort of little boxes in a bigger window, but it's largely EHR agnostic, which you really couldn't be in a real case. I have to know what I can do. What graphs can I put up in this EHR? So it has to be instantiated in a particular way. And again, I mentioned before, EHRs aren't monoliths, as folks know. So within the same system, they're very different by specialty. So providers in the mental health side who were in our meetings were like, I can't even see that metric you're talking about now. I can't see emergency department outcomes, and you can't see my mental health data. And so, how do we build a dashboard in that setting? So a lot of outstanding issues. Ethical considerations, metric validation, data privacy concerns, linkage and architecture questions. We are not there. We're not at the cusp of really implementing this, but hope to, these kinds of products drive us there. So again, reminder, here's where we're at. So almost anything is better. So the big themes from the stakeholder meetings then that we're going to turn into visual in the next slide is that linking data is important, but you've got those underlying privacy and ethics concerns that I've already talked about. Entity resolution, which is largely up to providers right now. So if you go into CSRS, the only linkage that they're doing is exact name matches with the same zip code. You can have a different address, I think, is the only automated entity linkage, which is barely anything. So if you make a typo in a name, that's a different person. If the birth date is off by a day, that's a different person. So providers then get, patients that were close to your, and they're not linked together, and so there's no metrics. And so this is the entity resolution problem here. And it should largely be out of the hands of providers.
Yeah, I've actually gotten the same patient with different addresses.
Yeah, as different people.
No, it's different people on the list. Yeah.
That's what I mean. So yeah, so that's the level of, we're not linking people with the same name and different addresses in cases are not. So so anything you build on a system like that is going to be pretty tough. But it probably still has to happen some. You know, there's going to be no perfect metric, and you have to be able to. If a patient says, yeah, but I also got a prescription for blah blah blah, you have to be able to on the fly do something about that. But it should be less for providers. So then, provider feedback also was that fewer key indicators are more useful. So you know, the most important one that they mentioned in meetings was, yeah, but have they had an overdose? I want to know if I'm about to prescribe more meds, I want to know if this person's ever overdosed, and many providers can't see that right now within the system. So simple indicators and visuals. So here's the tension, I think, that's kind of interesting to keep in mind. Indicators have to be simple and actionable, interpretable, but also pull in predictive analytics and hide private data. So I don't know how to do that. And so you know, there have been conversations about ways to do this that have been erring on the side of black box, you know, so behind the scenes, we're going to do a bunch of machine learning predictive analytics to crunch up and give you a score. And then that score is going to be used by a provider. How? You know, so unless we then test and say, yeah, but a score above 4.0 means this kind of a risk for overdose in our patient population. But then could folks even use something like that in a realistic workflow? So this is the tension, you know, more and more data, but asking a clinician to make an understandable, you know, on the fly decision. So real thing. So I'm not going to look at this. We're going to zoom in. But so we then produced a bunch of heavily annotated wireframes with prescriber and researcher feedback on the details here. We're going to keep zooming in until we can actually see something. So then one of those might look like this, where we've got, you know, annotated details for, hey, you know, link score thing, talk about that, talk about a date range and how we might build that, visual options. So, you know, these are the patients you're looking at. Here's the high match patients. Maybe you click on these and say, this is a true longitudinal story. So now we can really zoom into something specific. So again, this is idealized. So I don't know what your EHR looks like. I'm saying, imagine a CSRS module that lives in a small window in the EHR. Then you'd have some sort of overall, my notes here. In 2, you'd have some sort of overall, this is my best guess, most common name and address for this person. If there's enough problem with that, I need to flag this in some important way that says this is an untestable, or I would be mindful of interpreting this because you've got 3 very similar patient IDs that you need to resolve, if that's the case. If it's not the case, just say, hey, there's other folks, but it's not a red, really important problem. Most important flags, you know, were ED overdose and drug-related legal history. Can we do that ethically? We'll talk about later. We have a bunch of notes on sort of the ethics of this from researchers and prescribers. Most recent controlled substances, and then we talked about some different coloring schemes, or show 3 most recent or 6 most recent. This was the sort of culmination of a lot of different variations of metrics. So we're going to get into more detail when we go to where these come from in the prescription history set. But imagine a yellow, medium, high, highest risk score, but then has to be interpreted in some concrete and then evidence, you know, attached to a study of some kind. So patients, you know, with a high score were X% more likely to experience an ED visit or death due to poisoning overdose than some average. So that's sort of our best guess at, well, if you want them to have some black box, the best we could imagine in terms of an interpretable metric would be something like that. Opioid load, which I think all the researchers agree we can't do this, or it would be very dangerous to sort of make it as something simple as MMEs per day. We'll talk some about details on that. And then this shopping score or network score and a distance score as ways to think about driving to many prescribers and providers, prescribers and dispensers. So on this patient link side, I mean, we should be doing as little of this as possible. So maybe high scores over here get automatically linked by some algorithm, and we say, if you want to know how I'm building this individual person, here's that patient and those details, and then those link scores. providers across the board said, I'm hesitant to go and start linking people that I don't know are really the person because of HIPAA reasons. I mean, and so like relying on, hey, this is a 60, maybe don't go in. Maybe we have some formal threshold that says, unless the patient says, that's me, you don't get to go in and make that link to look at these details. Or I don't, So this is the kind of tension in asking providers to do this, and how some of this has to happen in some way. So this visual timeline is, imagining something like this. So you can say like folks colored by score might be more likely to be the person. If you can see some sort of continuous history, you might be more likely to think it's them. So on the, I'll start with the legal side. So we left this wholly blank to emphasize I don't want to start putting ideas in people's heads without talking about legal considerations. So we just listed it and then had a bunch of notes of the ethical considerations. So providers were interested in seeing it, but also had questions about HIPAA and legality, HIPAA not applying in the same way to non-health data in this case. And then researchers, and community workers on the side of stigma and bang the box and, those kinds of tensions for providing legal data outcomes here. So ED history, we talked about not needing to see all of their ED history of all time. Some folks have extensive ED histories or use the ED almost exclusively for medical care. So it might be most recent, and it might be all the overdoses, or doing those, even those ICD code, ICD-10 definitions for an opioid-related visit are non-trivial. So a lot of details to work out, but folks wanted to see that history in some way. So into some of these more detailed questions, we're going to get into some of the MME issues once we get into the research document. But folks are interested in some sort of an opioid load score, MMEs per day, or prescribed MMEs per month, or it's actually dispensed MMEs per month, because you could be prescribed MMEs you don't pick up. This is, again, you could use 2 and then dump the rest in a Dropbox. We don't know what people are really doing after the pickup.
Just to quickly interrupt, there it says all patients. I thought this was in the context of a single patient that you're linking across.
Yeah, so if you wanted to compare, so this is a single patient, but so in terms of interpretability, we're trying to build metrics that a prescriber can use in the sentence. So if this is a 20, that's, hey, you're averaging 20 MMEs per day, that's greater than 20% of the population, of the all patient population. So, but you might like to see compared to your single provider or compared to a specialty group, or so that's changing the comparison population. Okay. Yeah. Which matters a ton. So providers say, I'm not interested in comparing all of my cancer patients to all patients of all time or all of my pain patients. But you don't also get to see, like I can't say, show me, compare it to Dr. So-and-so over here. So those kinds of aggregate metrics to say within UNC healthcare system and this specialty, I could build a distribution and save that de-identified distribution as a comparison point for this. So there was some conversation with the informatics folks on what could we actually get you on the short side if we can't get you identifiable data. And we could at least send into a system, into an EHR, de-identified distributions from our side that folks then might be able to incorporate in their own into the EHR, even if we can't send the informatics, the individual identifiers. A lot of tensions. Again, similar story with most recent controlled substances, maybe highlight all of the most recent opioids. Opioids aren't the only controlled substance, but a big chunk. So we talked about the risk score some. There's efforts now, a contract now with SAS to do the beginning of this, where they've got CSRS data snapshot and are looking at, well, they have CSRS, but they also have other data sets and are beginning to sort of link that data and look to build some sort of a risk score. But again, interpretability for providers, usability by researchers, validation is all really important questions. And then visualizations of timelines. So maybe this is, you can see sort of a more and more dense opioid utilization over time for this particular patient. And lastly, this question of networks. So there's some beginnings of research and existing metrics on shopping broadly. Doctor shopping is sort of the frame. But some people in rural areas have to travel long distances to see providers. So this is sort of a tension. CDC has a metric that they use, a binary metric of at least if you see 5 prescribers and 5 dispensers within 6 months, then that's a flag. We should use that in some way. There's limited research on whether or not that's actually attached to risk outcomes. Seems bad, and I was in our data. This is one of the measures that I was really digging into in North Carolina CSRS data. There are very few people who do that, 5 and 5. But some people then see 30 and 10 in that group. But we're looking at a recent data set in West Virginia, and they had actually done this linkage already and started to evaluate what this threshold should be from a sensitivity analysis point of view. And they were seeing, I think they reported 4 and 4 or 3 and 3 was their most useful cut point, where they're getting better both sensitivity and specificity looking at their outcomes for overdose and death. So 5 and 5, I don't know, but we could still, if it weren't a binary, we could compare it to the population and say who in that population has that kind of distribution. And then same with the distance score. Provider, which providers you've seen for which substances might be useful, here, here, and here, and which dispensers you've seen, and some map that zooms might be useful if a provider knows, oh, I know where this patient should be going, and why are they traveling here, here, and here. So this is sort of the last of these, and I'll say CSRS EHR use for providers to help better prescribe to patients isn't the only oversight that CSRS provides. So CSRS can also do oversight with providers themselves. So providers intentionally diverting or distributing opioids. So the focus on patients only, when we've looked at, where the industry is being sued by many states and local municipalities, and individual providers have also been investigated. So this is very patient-focused, but there are other ways to use this and other dashboards that need to be built for other uses here. So talk then about data quality assurance. So out of these conversations, that MME was a good example, or the 5 and 5, that I went into some more depth with, are examples of metrics that we're using or talking about using without the underlying evidence base for. And it's tough when we haven't done these linkages and when these data sets are big and siloed, you don't then get to do that metric work. You can imagine some metrics, at the national level, but whether they apply to rural areas, same as urban areas, is tough. You have to do the research. So, based on my own personal experience, so I started the project at DMH, where I was really working with the data on a regular basis, and so typically previously they were working with the data again in big chunks, and I considered it an effort to normalize this data set and gave up, basically. So instead of taking big sort of horizontal chunks of the data, I would take long strings of just a few records at a time that I could likely ingest on a single system at a time. Again, they don't have a database set up. They just have it on a shared drive, about 150 gigs file on a shared drive, just sitting. So, again, I had some conversation with IT about setting up a true database in our system or normalizing the database in some way. So instead, I take these long strings and try to take 3 or 4 records at a time to understand longitudinally from 2009 to now how has this data set changed on some of our key metrics. And that was helpful to see, we have 200,000 blank identical records in a county on a day, and that's a problem. And those are the kinds of problems that weren't being. And then I stopped. I was like, there are issues with data. We got to have a plan. It's not for me to do. So that was my own, and then built some spatial and outlier searches without getting into the details. We weren't doing a lot of spatial work before or geocoding and using those geocodes to look at spatial distance in the same way. So I have some background in that, so I poked around. So after my own work, then I went to what is the researcher universe. And there's not that many people who work with our data set directly. And I think I talked with almost all of them. And we called former employees who were there when the data set started in 2009, now working at the CDC. Previous students who are now graduated, who got small snapshots of the data. Maybe they didn't get all the fields, but they got some sets of the fields, and had some individual and group interviews with folks to say, how are you using this? What worked and what didn't? What are your biggest concerns in the metrics? So a lot. So we ended up finishing with this appendix, which we're not going to dig into. I'll give you the highlights. but that we hope is usable both by DMH, but then also their vendor. So again, I think the plan is not entirely, but partially to ship out the data quality question to a vendor like SAS. And we think that being an opioid-specific researcher helps, and it takes a team. It takes a broad content area team to do this well. And so we hope some of these lessons learned that we've attached to this document can help the research team as they're building metrics and cleaning the data. So the big lessons from this conversation, improving data entry is really important. Researchers who had worked with some of these fields were like, there are obvious problems that they're not cleaning on the UI side. So you've got dispensers who are entering names in the birthday field that should never have accepted that data entry point. It's like it's obviously not a date. You can't put it there. And so without those kind of cleaning, on their systems, we get garbage data. Cleaning those primary fields that are most useful, so we build a lot of metric combined aggregate fields after that. Really, again, harping on this NV resolution piece, but it's really important. So that has to happen in a system, and states that are doing this well. So Kentucky has an IBM built pipeline that does this live as it comes in. So every new input is immediately attached. So it's not like batched, where they're going to you put in a week's worth of data and then they try to merge it all together. But they take every new entry and try to find its best guess, and that's constantly rolling. That was one of the pieces of feedback on a SAS-based system, was that their experience with SAS was that they were batching, and it would take weeks to run and wasn't approachable. I don't know that that way anymore, but that was their experience. So working on these descriptive and predictive metrics and checking that they're valid, meaning you've got to have some linkages and really know what those metrics mean and what they do. Appropriate error feedback. When we crunch data or find new errors, we have to go to the right people and some process in order to do that, to say, CVS, you have this thing that allows you to put names in the birthday field. This is not okay. Can we talk about it? Alex at CSRs has some of those relationships as managing this. That's managing your scripts and supplementary tables. So when I was there watching the scripts run, it's sort of like, I think this is mindful of my language. So it's important to have either a Git based or some commit system so that you know the most recent script. When the changes were made to the script. This is kind of production level, really important public health content. And so if it's just, where's the most recent script on my local drive? I think I backed that one up. Any of that stuff is sort of not enterprise level data behavior. And then there's a lot of supplementary tables that get pulled in here. So I'll give an example. Actually connects to some NCD Tech conversations we've had where they're attributing county 100% of the time from the city. And so the consequence of that to all of our reports, when cities cross over county lines, not infrequently, has all these problems for how we generate metrics that we're using at the state level on the regular. I think the system geocodes, which we haven't validated. So we have addresses which are geocoded, but we haven't checked some subset of those geocodes to make sure that system works well. But those geocodes, that's a very trivial math operation to take a point and overlay it onto your shapes and attribute county that way, rather than with a table. And the table gets out of date as county boundary change. So just all that stuff takes documentation and continuous improvement. So we got to then integrate that ever-evolving content knowledge. So I am not really an opioid expert. I'm probably getting there more than most people, but every person I work with on this knows opioids better than me. That said, folks are saying, hey, I'm not a prescriber. And so when we have folks who are researcher prescribers in our case, and like, yeah, but when you prescribe dupes, it doesn't work that way. And I'm like, I don't know that, but that has to be, that's why you can't just be a data person working with this data. You need the context person. And then lastly, data quality reports, which has sort of been a heartbreak. When I was there, I was like, it would be really great to structure out every time any data comes down, you run this, and then you're getting basic distributions and looking for key errors you saw in the past that you think you fixed but are now back. That's the kind of, it has to happen on a regular basis, and there has to be a steward who has an automated process for not just running the metrics we need, but running the data quality reports that we need to check. So there's a lot there. So I've actually now talked about these two in some detail, the MME calculations piece. So for instance, I'm not a prescriber, but feedback from prescriber researchers in our team were like, well, oral tablets work like this. but it depends on metabolism and body weight. And like a patch, this is a good example. Like, so if you have a patch that says the total MMEs dispensed is this, if you use it as a patch, you can get more MMEs out of it if you boil it or chew it. And so there's actually more MMEs being dispensed in a patch than is attributed to the patch on paper. And so it's content knowledge like that that says, well, you've actually given this person twice as many MMEs as you think if they start chewing the patches. So details matter. Researcher content agnostic data science doesn't work by itself. Talked about some detail, which I won't get into, on the entity resolution piece. And we talked about same things providers said in terms of avoiding black boxes and prioritizing workable metrics. Lots of ethics concerns that we brought up while we're talking about data, particularly on that linkage thing. We've talked about, I think, all of these in this case. So again, I'm thinking discrimination, like ban the box pushes that now have an HIE, HIPAA consequence. When we start linking all these data sets together, including legal outcomes, how do we treat that data ethically? So last, there's a few pages of just sort of general informatics considerations that almost feel like they're appropriate for just about any project. So hey, as we're linking things together, you got to be really mindful to document and make sure they work. Our ETL operations. So some states get data every day. We get data every month from our system. Some states have automated linkage live, basically. Other states batch that linkage process. Some folks, that linkage process lives in a third-party vendor in somewhat of a black box sort of way. Other places, they're doing it in-house in a DHHS equivalent, basically at the state. A lot of variation there, and documenting and making decisions about those individual operations is really important. Automation, documentation of cleaning and reporting, we've talked about. Moving to a more push and alert-centric system while avoiding alert fatigue is really important. So you can't expect a prescriber to read pages of material when they need, like, an at a glance, hey, give me just what's the gist here in terms of a person's opioid load. And then assuring data quality is really important. So particularly as we get into calculated metrics, we're having that 5 and 5 conversation based on a correct entity linkage. So and correct underlying data. So you don't get to have that conversation if the underlying data to build that metric is wrong in the first place. So we've really it takes a lot of steps to get to a valid metric in this case. So then lastly, on this project, on the CSRS 2.0 project, data reports, really important. As we're thinking about a new CSRS, it shouldn't be limited to existing fields. We might want to collect other things, have new aggregated metrics. And then data privacy and data governance broadly, we've talked about. Data security is sort of always a given. Yeah, there's a lot. There's a lot of considerations. So the final deliverable then, and this is the end of this project, was an executive summary, a 2-pager executive summary you can read really quick. The overall sort of core report is whatever this is, 10 pages, 12, 14 pages, something like that. And then a lot of big appendices. So we've sort of summarized all the wireframes here, but then there's a 3-page detail wireframe set somewhere else. So it's sort of tiers that we tried to make it digestible so that if you just wanted to read a one-pager, you could do that. So I'm going to take about 5 more minutes to present a quick version of this project too, just to sort of see where do these metrics go, and what's sort of the end run on this. And then we'll have about 10 minutes for questions. So why a data dashboard? This is, again, a separate initiative with the public health side of things. The previous was a collaboration with IPRIC over the course of about a little less than a year, and DMH. So DMH, DPH, sort of sister organizations within the DHHS umbrella. So opioid data, there's a lot of it. And from an intervention point of view at the public health level, that's multiple longitudinal metrics from many different data sources. And so if you're at the county health department and you want to be able to get that data, that looks like, well, first I'll go to the DMH page and get the data if it's still up online. Oh, it's been pulled down. Oh, we'll go over here for this. And so getting everything in one place was useful for counties, as well as for the state, which had established an opioid action plan in summer of 2017, so not too long ago. So previously, there had been a lot of, hey, everybody send me the data, not me, but send sort of a similar person to me at the state, sent their data, and then they built some Excel-based tools and used VBA to collapse them and rerun them and update them, which is better than doing it all by hand every time, but still not online or friendly. So there's desire to test the system. So in this case, we went deep on R Shiny. I think DHHS is likely moving to Tableau, it looks like, though that investment is a $500,000 investment. So fingers crossed that that does the work that they need. And then we wanted to build something that we can then add future metrics and get data to the county level. So the metrics as they are now are only state, and as of this thing that we're releasing this month, do a preview on, there's county level variations in all these metrics. So the process was kind of what you could imagine, sort of a pretty lean process. We started with a bunch of paper opioid metric designs. We did a nationwide search for who else is building these things. A few in R Shiny, some in Tableau, some custom JavaScript work, totally customized. Some folks just plopped up tables. I mean, a lot of different variation, but about 30 or 40 different states have something. So again, built some paper wireframes and some early prototypes in R Shiny to help, particularly me who's doing this development, pick the graph and map packages. There's a lot of options there for JavaScript-based, how you want to build a map with Leaflet or Mapbox or Pick the Thing or Plotly or variations on interactive graphs, high charts, whatever. So then a lot of iteration with state partners. We tried a bunch of things that we ended up dropping, so we sort of overbuilt it and then rolled back, which is a bummer, but we get to see it and then see problems with it and then say, oh, we're not going to put that extra bit of intelligent machine learning, colored curve in the thing. We're just going to do this instead. A lot of debugging, a lot of fighting browser peculiarities, Internet Explorer, and so we ended up building it in R Shiny with a JavaScript HTML widget package that lets the basics be sort of interactively linked from R to Leaflet and Plotly, and then a bunch of Dreamweaver work to sort of touch things up and some customized CSS. So it ended up being kind of a lot of languages in one set. I feel like I've talked about some of these technical challenges, so yeah. Oh, I do want to say one move that I feel like I'm happy about. So we don't have a CMS for this, right? So a content management system that would allow you to be allow a non-coder to go in and change some of the text. That's in about 1,000 lines of code. It's buried in 1,000 lines of code. So we tried to figure out some way to get around that, and we have instead a bunch of flexible Google Sheets. So a person can go into the Google Sheet, a private Google Sheet for them, change the text, and it's going to put that summary of the most recent quarter's data into the tool. And we found there was a nice balance of, not going to prop up a whole new CMS for this, but still allow our Shiny to go pick up for more recent data. A lot of different formats from a lot of different partners to get this data to come in one place. We tried to standardize it, but it didn't all work. So there's a little bit of touch-up. From an epidemiology point of view is really where we found the challenges, and they're still going on. So suppression issues with at least one of our data sets were tough. Small numbers, we ended up smoothing a lot of data. We smoothed all the data, as you'll see in the graphs, and then in some cases we only showed smooth data as a way to get around this data suppression problem. Data speed, so all of these data sets started at different points, ended at different points, and we ended up deciding on just a consistent time period for everybody, and we just blank out and say no data for data that doesn't exist, because it's very easy to show 10 graphs and everybody thinks that they correlate when the times are all different for everybody's data part. So tough. Defining trends, I'll get into an example of later that has some interesting detail, but do we use the most recent data, last 10 data points, last year since the Opioid Action Plan? So many ways to define a trend and interpreting matters. What do we do about these metrics? So if something's high, how do we act? And we're still developing that. And then next steps, we're building on to this system. I'm going to skip this. So these are some of the things that came up out of the feedback and iteration process. Things we dropped and decided to add that were important for us, but we'll just see what we end up with. So I'll give it a live demo in a second, but as an example, so we talk about trends, and we're currently still chewing on what is a trend. So here's opioid deaths, North Carolina as it's live, as it's real data, actual data, and here's a low S smooth line. Many ways to smooth. Here's one. We first defined a local trend, because you might want to know in your county, is this going up or going down? we first defined it against all data, but then it's like always going to be up for all time. They have to wait another 20 years for this trend to go down. So then we decided we'll look at the next 4 points. So we have a system that I'll show in a second that looks at the next previous 4 points and does a crude trend check for the last 4 points. But in that case, opioid deaths are going down. And I don't know anybody who'd look at this line and say opioid deaths are going down. But these last 4 points have a slightly downward trend. And so this is the kind of interpreting that, like, we're having conversations with Susan at the state and the governor's office on press releases for this. And so if we put a trend arrow that says down next to this on a thing, that becomes a press release. And like that's the conversation we're having is like, take those trend arrows down. We got to know what does this really say because it's going to be press released. And what's political and intelligent for us to say, what drives change. So it's not just, it's true, this is going down if you measure from the last 4 points. And then, so again, now I've got 13 other metrics that look like this. And all of those trends are a little bit different and a little bit nuanced. And if I pick a county that's very sparse, how do we do trend? So it's all those details we're still chewing on. There's a lot. And then we did a bunch of maps. These mouse over so you can see the actual data. But from an epi point of view, percentile bidding makes really nice looking maps. But if we're in an epidemic, who's low here? Who's seen? In this case, last quarter you didn't have deaths. Congratulations. But it used to be that was the norm. And so when you're up in the top of a curve, local variation is a little bit confusing. If we want to say, yeah, but these are all high. So, or compared to an opioid death rate in the 80s or something like that. What are we really doing with this, pushing this variation here? So 2 screenshots. So this is the landing page we ended up with. We ended up taking a lot off the landing page, so it was very simple. We didn't want to present people with data too early. So you get 4 data points. We found people showing them this more detailed metric table. This is like an expert version of the table. It's got all the metrics, all the data, its most recent trend. We pulled off about 10 other columns of too much data on here, and we're probably shrinking even more and more. So landing, and then sort of next page for folks who just want a quick look. And then the actual tool looks like this, where you pick a content area. You can pick, drop down the top for which North Carolina or county you want. Then you get a graph and a map and a graph and a map, and it updates as you change the county. It's very simple. There's one tool, one location changing tool. So this is actually I'll have this loading. I'll load up the web page while we do questions for a few minutes. So thank you. Thank you for listening to that dense talk for 55 minutes. Any questions?
Have other states who've done the pilots of the integration, the EHR, PDMP integration with EHR, what sort of costs are they?
Costs?
Yeah.
Great question. I don't know. Yeah. I mean, it was really, so I think I focused mostly on functionalities. And even though, I haven't seen any of these systems working. This is sort of all phone. I believe you because you say it. It's not that I mistrust partners, but it's it can sound better on paper than it is in practice. So yeah, I don't know. Hopefully finding, you have someone from Tennessee and Kentucky coming in May to come to a roundtable discussion. It's a more focused discussion on this. And I imagine, cost is going to be part of that conversation. I know we're spending money on this already, so.
So my understanding, I just spent a little bit of time in Charlotte, and our former prospective partners at Atrium Health got a CDC grant to build a dashboard for their providers, and the program is being run by a PA in orthopedics there, and you might want to talk to her.
Interesting.
Because that's something that's being done in state, and she was giving me a few case examples of how they were, for instance, informing a prescriber that this is a person that's risky to prescribe to.
Yeah, interesting. And so that would have been based on sort of within their healthcare system data, right?
Yeah,
so within UNC Charlotte's.
Yeah, and they're putting it into their Cerner EHR.
It's a Cerner, got it.
Yeah.
Yeah. Yeah, there are a lot of partners. I mean, it's just what we're finding is that like folks are instantiating things within their own healthcare systems and are ahead. You know, our conversation with Duke was like, well, we've been having this conversation for a couple years, and here's what we've already built. Yeah, so I'm certainly, I'm not the right person to follow up in that context, but I can find the right person for that context, and it'd be great to have.
Yeah, of course, after the announcement, I was kicked right to the street. No, just
except for you. Yeah. So this is that system, though. You get the sense. You pick a place, and then you get these data points. This was the time that the opioid action plan rolled up. You can do your mouse overs for your data.
So are some of those high death counties showing downward trends and are still high death?
Yeah.
So
So
I see Burke County, the Scotty dog.
These are counts of last quarter because the decision was made for again interpretability reasons to push everything to the quarter. Though technically, like this is quarter 3, 2017 because it takes that long for death records to really show up in our system. And yeah, I mean, there's a lot of moving parts. So right now it's like death is slower, but like if you define a trend as like what's happened last week, technically something like NC Detect could do that. We don't have a lot of deaths, obviously, but like ED visits or something, you could look over a month or a shorter period of time. Again, right now, so answering the question of is it going? That's a great level question. Is it are some of these high counties going down? Let's start talking about what all those things mean. What's high and what's low.
So this is a place where I think visualization might be helpful in that if you mouse over things, could you, instead of saying up or down, show the trend, right? And people can start to see that shape and then interpret, is this really going down even though the last 4 data points are? I see the longer term, and the picture will show you both the short and longer term trend in a way that you can digest. But then it's making it easy to get to the more detailed information.
Yeah, that's interesting.
The other thing is to think about contextualizing some of this stuff. So like the last 4 data points, is that going down? One thing that might be useful to overlay over that is the variance, so that you get a sense of it's going down, but it's within the band of normal fluctuation. So this is not interpret.
One of the things we used to have was that. So we had that trend line, the short trend line here. We had the standard error around this low S as well as the trend line. And the feedback from our non-stats partners was, I have no idea what you're talking about. And that's it's tough because that's what you need to make that decision, right? Or it's what a stats person would need. All they would need is to say if this line is outside this thing or within this gray bar. Right. But we took it out.
So one question we could follow up later, but it'd be interesting to see how that error bar was presented, because I think part of it is not using the language of a statistician, but just saying, we'd expect it to be somewhere in here. I think you get this with like hurricanes, right? That forecast track of what does that cone of uncertainty really mean? Yeah. It's really hard to communicate uncertainty to people, but it's also important to not ignore.
No. So what we've decided to do for now is to pull out a lot of those features and simplify with the idea that next quarter we get to add features for folks who are then more familiar with it.
Makes sense.
Job.
So fantastic work, very inspiring. I think it's hopefully we can capture this presentation and feature in our website of all the projects being done under practical projects under the master's program. I've had like 5 different ideas just pondering. I had it very difficult to focus because this is a model example of where government, academia, and hopefully increasingly private sector can engage in a very serious way. You're studying opioid, but this could drive us to think in a broader frame of ideally informatics or data science driven policy. And doing it, I can envision a day we would do this almost in a real-time way. So before politicians open their mouths and say weird stuff,
Good luck.
that there would be a way. Now I'm being facetious, but let's say before politicians come up with the next big legislation, right? Having tools like this, and that actually work, can be useful for people who are not statisticians.
Yeah, I mean, without getting into it, lobbying is a part of this conversation that I didn't talk about, but is an active part of all of these conversations. Like many of these